and good evening, everyone. I welcome you all for today's webinar on Oncology Express. And with immense pleasure, I would like to invite Dr. Manish Sharma, who is Consultant and Head Medical Oncology at Action Cancer Hospital, Delhi, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Good evening, and thank you all for joining me here. And today evening, we will be talking about lung cancer and the nutritional status of our patients. What are the different studies in the lung cancer at the moment? What are the different biomarkers? What are the different kind of treatment which is available for the targeted therapy in the non-small cell lung cancer space? And something about the nutritional requirement of our patients. How does the patient suffer nutritionally, and what is the role of protein in the maintaining the nutritional status of the patient? So for presenting the today's topic, first topic is choosing essential biomarker on NGS in early stage lung cancer, early and late stage lung cancer. And the speaker is Dr. Praveen Jain. He is consultant and head medical oncology at Akash Institute, Dwarka. I welcome you, Dr. Praveen.
So thank you, Dr. Manish. Let me share my screen. I hope my screen is visible and I'm audible too.
Yes, yes.
Okay. So first of all, I would like to thanks Dr. Manish for giving me this opportunity. So the first talk is on molecular biomarker testing in lung cancer. So we know that there was a time when lung cancer, they were being treated with only conventional chemotherapies. Then was a time that broadly we used to categorize the lung cancer in with the help of the histology per se into non-small cell and small cell lung cancer. And then there was a time when adenocarcinoma and squamous cell carcinoma differentiation we could make because of the help of IHC. And after that, there were few markers which were initially detected like EGFR, AL, cross, and now we have plethora of targetable mutations or aberrations which we have in lung cancer, and almost it is now the dictum is that almost all the adenocarcinoma patients, so they have some or other driver mutation, and the only thing is that we need to have a good testing platform to identify those genetic aberration. So with this, I would like to start the talk, and I'll be speaking about the lung cancer in India, about the biomarker testing in non-small cell lung cancer, then the evolution of biomarker test in non-small cell lung cancer, what was the past, what is the current, and what could be the future. And then we will discuss the key takeaways. So if we see here in these pie chart, we can see over here that lung cancer, it is one of the most common cause of cancer in India. And if we see, it is the second most common cause of cancer in males, and it is one of the most common cause of mortality also, cancer associated mortality. So, but if you see over here, so that the breast cancer, so every year, so the new cases are 1,78,000, and the lung cancer is 72,510. And if we see the 5-year prevalence of lung cancer, so it is close to the same what we are detecting in a year. And if we see the other cancer, so it is almost 3 times, 2 times, 2 times. So the crux of this table is that the mortality of lung cancer is quite high, and it is definitely an unmet need, and we need to improve on the outcome of these cancers. So this is again a pie chart, which is this was a study which was published in 2021, and so we can see over here that these are the mutational landscape of non-small cell lung cancer, and more than 50% of the patient with advanced non-squamous non-small cell lung cancer, so they have some druggable mutation. So the most common among them is the KRAS mutation, and out of which 50% are the KRAS G12C, so which is being targeted with sotorasib and adagrasib. So then the next most common is the EGFR sensitizing mutation. In the Western world, it is to the tune of 17 to 20%. But if we see the Asian literature, it is to the tune of 32 to 35%. So again, so there are a lot of drugs which are available for EGFR target. Then the next common mutation is or genetic defect is so the ALK rearrangement. And now we have a very good test for ALK rearrangement, that is ALK by IHC. And Ventana is the platform which is used for detection of this ALK. And we do have a lot of first generation, second generation, third generation agent for targeting ALK also. So there are other less frequent mutations like EGFR exon 20 insertion and MET amplification, MET mutation, and HER2 mutation, HER2 amplification, then ROS1 rearrangement, BRAF mutation, RET mutation, RET rearrangements, and NTRK fusions, PIK3CA amplifications, and MEK amplification. So these are all the druggable mutations or amplifications, so which can happen in non-small cell lung cancer. And now to the tune of that almost 2/3 of the patient, we already know that these patients, they have some genetic aberration which is acting as a oncogene. These cancer, they are behaving like a oncogene addicted cancers. So the importance of biomarker testing in non-small cell lung cancer is that the initial studies, they have shown that the patient with identified actionable mutation who receive appropriate targeted therapy, they have definite improvement in the outcomes of the patients. And we have seen in quite a few number of studies with different targeted therapies, so that it leads to a definite improvement in progression-free survival. And even after the crossover designs of these trials, so there are overall survival advantage. So I remember in early 2000s, so when conventional chemotherapy was the only answer, so there the median overall survival with the chemotherapy was 6 months in lung cancer. And now we have gone to 30% 5-year overall survival. So which is a tremendous improvement. And most of this improvement, it is because the involvement of targeted therapy and immunotherapy in the treatment paradigm of non-small cell lung cancer. So these are the guidelines recommendation, and across the board, be it ASCO guideline, NCCN guideline, ESMO guideline, or CAP guidelines, so they recommend at least these 9-10 genetic aberrations. So testing for 9 to 10 genetic aberration, and the list is there is expansion of this list day in and day out. So EGFR mutations, ALK rearrangements, ROS1 rearrangements, BRAF mutation, MET exon 14 skipping mutation, RET gene fusions, NTRK gene fusions, KRAS mutation, particularly G12C, then BDL1 expression. So, and there are a lot of commercial panels which are available, which are testing for all these genes. And the results also, they are easily available and rapidly available these days. So we will talk about these tissue testing methods. So the tissue testing method can use DNA sequencing or RNA sequencing, or we can detect the protein also with the help of IHC. So DNA sequencing, so it is done with the help of NGS, PCR, and they particularly detect insertions, point mutations, deletions. So like PCR is able to identify those mutation which are known mutation, and we have probe made for those. NGS and the comprehensive genomic profiling, so they particularly look at the known as well as the unknown mutations. So coming to the RNA sequencing panels, so RNA is particularly very useful for detecting the fusion abnormalities like ALK rearrangements, ROS1, RET, and TRK fusions. And it is very, very important to detect these less common fusion abnormalities, because these patients with fusion abnormality, so they behave better as compared to the point mutations in other genes. And the outcome of these patients with the targeted therapy, corresponding targeted therapy, it is very, very good, and they improve a lot. So with IHC, so we can detect ALK, so which is a like very well tested and old mechanism, but we are testing since last 5 6 years. So we have good concordance between the IHC by ALK and IHC by fish and IHC by NGS testings. So ROS1 is also, so there is a screening method which is done by IHC, and if ROS1 by IHC is positive, so we have to confirm it by fish also. So these IHC, so these are easy, rapidly performed, and they have a very less cost associated with them. And IHC also is helpful in detecting the PDL1 expression on the tumor cell and the IC cells. So coming to the evolution of biomarker test in non-small cell lung cancer. So we can see over here. So this is a very basic slide. So that what is the source of the like tissue specimen? So it could be a resection specimen, it could be an excision specimen, or it could be a small tissue biopsies. So these are the tissue biopsy methods. So then there are cytologies like urine cytology, ascitic fluid cytology, pleural fluid cytology, sputum cytology, CSF cytology, and residual supernatant. So basically these fluids, body fluids, so they are used, and a cell block is made out of these fluid. And we can also make a we can also do IHC testing on cytology if we have made the cell block out of this. And for this, cytocentrifuge is the device which is used to make the cell block. So then there are methods like liquid biopsies. So the liquid biopsy, they particularly look at the either the circulating tumor DNA or the circulating tumor cells. So these are two areas so which are very innovative, and it's being used day in and day out nowadays, because the tumors, so they are heterogeneous, and most of the tumors, if the burden is high, so they shed tumor DNA into the blood. And in fact the tumor cells are also shed into the blood, and these DNA and CTCs, they can be extracted from the blood or the other fluids, and they can be used for testing, molecular testing. So on the basis of these specimens, on these specimen, histology can be performed along with the IHC, then cytology can be performed on the fluids, and the molecular testing also can be performed like on DNA, PCR, gene panels, MSI, so targeted mutations. Then RNA also, reverse transcriptase, PCR can be used, or gene expression panels or RNA sequencing can be used, and or proteins, proteomics, and PACS, it can be performed. So biopsy, so it is the initial step. It establishes diagnosis, and it determines the histologic subtype, and it also make us available the biomarker testing tissue. So his histological subtyping, usually non-small cell is done classified into squamous or non-squamous histology. For biomarker testing, primary tumor and metastatic lesion, they are equally suitable. And it is said that the biopsy should be performed from the most easily accessible area. So one thing which is very important to consider, so bone biopsy can be suboptimal due to decalcification, which leads to degradation of DNA. So the molecular testing on bone biopsy, sometimes it becomes very tricky, and all the centers, they do not have the facility of decalcifying the tissue and doing the test on the bone biopsies. So liquid biopsies are another option, but there are certain limitation to the liquid biopsy also, like the IHC analysis that cannot be performed on liquid biopsies. However, there are newer method where CTCs are being used for IHCs, and people are trying to validate this approach. But as of now, liquid biopsy, it is only for molecular testing what we are using. So then the test for EGFR, ALK, ROS, BRAF, V600E, and track fusions, RET, MET in all non-squamous, non-small cell histologies. And so there was a concern whether to use a single gene-based testing or a broad NGS testing. But nowadays, the consensus is to use broad next-generation sequencing platforms. So where we get to know not only the known mutations, we also get to know the unknown mutations or the fusions. Then the test for PDL1 expression is important in all non-small cell lung cancer because those patients who are not oncogene driven tumors, so they are candidate for immunotherapy either as a monotherapy or as a combination with chemotherapy. And the recommendation is to complete the molecular testing within 10 to 14 days of the biopsy. So ctDNA or circulating tumor DNA testing, it has the potential to be applied across all stages of non-small cell lung cancer for the diagnosis and treatment selection. So for diagnosis, we had discussed that there are few companies or organizations who are trying to use CTCs or ctDNA for the diagnosis of cancer, but as if now it is not validated. But yes, ctDNA genotyping is recommended for clinical use in advanced non-small cell lung cancer to guide the treatment selection under specific circumstances. So it is also used to monitor the prognosis and response to treatment and progression or relapse of the disease. ctDNA testing overcomes some major challenges associated with tissue testing, like tissue is always an issue in lung cancer, and at the time of recurrence, getting an adequate tissue for molecular testing, it becomes sometimes very tricky. And in fact, in the primary setting also, sometimes getting the adequate tissue for molecular testing is also an issue. So here, ctDNA based platforms can be used to at least perform the molecular testing just to know the molecular aberrations in the tumor. So, but ctDNA testing may never replace tissue biopsy entirely, but could have a complementary role to support treatment selection in patients with non-small cell lung cancer. So, the guidelines recommend to use both liquid biopsy and the NGS on FFPE to get the best results out of the tumor. So ctDNA may be used to detect MRD after surgery in resectable non-small cell lung cancer, and this was the Tracer X study. So where 24 early stage non-small cell lung cancer patients, they were followed longitudinally after resection, and 93% of the patient with disease recurrence, so they were MRD positive, and only one patient with recurrence, so that patient was MRD negative. So on the other hand, 90% of the patient without recurrence, so they were MRD negative. So this is something, this is the future that in the Tracer X study, so what they have done is the ctDNA profiling. So it was able to confirm MRD negativity and detect MRD in patients who relapsed before their disease was picked up by the standard imaging. And these will be those patients where a treatment escalation could have been done to prevent the recurrence. And those patients with MRD negative status, a de-escalation strategy can also be tried. So the comparison of tissue versus liquid biopsy. So we've been talking multiple times in different forums. So the sample acquisition in case of tumor tissue, it is invasive. However, it is simple blood draw in liquid biopsy. So serial testing challenges are there with the biopsy because of the tumor heterogeneity, because of the repeated acquisition of the biopsy. So it is a little tricky in case of tumor tissues. In liquid biopsy, it's a minimal invasive procedure, and it is more reproducible as compared to the tissue. So the correlation with histology and cellular phenotype is possible with the tumor tissue, which is not at all possible with liquid biopsy. The sensitivity of assay in case of tumor tissue, so it is lower, tumor content also is acceptable, but for liquid biopsy, a very sensitive method is required, as ctDNA may comprise only 0.1% of the cell-free DNA. So because the tumor content is where tumor DNA content is very less, so liquid biopsy, it has to be a very sensitive test. So analytical standardization. So in case of tumor tissue, it uses existing validated tissue processing and handling procedures. So, but for liquid biopsy, the analytical performance characteristics of cell-free DNA or ctDNA, they have not been established, and there are no guidelines which recommend the performance characteristics of the liquid biopsies. So the clinical utility, also the substantial evidence for initial targeted treatment selection and subsequent treatment after targeted treatment failure in advanced non-small cell lung cancer. Similar is with the liquid biopsy also, but apart from this, liquid biopsy can be used in like uh, tandem with the therapy, and parallelly we can see the development of changes in the genetic makeup of the tumor, so during the therapy also. So sequential blood draws can be done during the treatment, and the genetic changes, they can be monitored with the help of liquid biopsy, which is very difficult in tumor tissue biopsy. So this is, again, we have discussed the single gene based testing versus NGS based testing. So if we have done the single gene based testing, EGFR identified, we give targeted therapy, no negative. So we go ahead with the chemotherapy. So if it is ALK positive, so whenever a genetic mutation is identified, so we give the targeted therapy for that. Otherwise, we go ahead and give chemotherapy. In next generation sequencing, also we do multiple tests at one go, and then we have the results of all these genetic aberrations at the same time. And if there are any targetable mutation, we go ahead with the targeted therapy. Otherwise, we go ahead with the chemotherapy. So what are the advantages of NGS? So it has got a number of advantages over single gene test. So it detects a broad range of molecular alteration in a single sample, and it may identify new marker that could offer additional treatment option for a patient. So, however, the cons of using NGS versus single gene test are that it is highly complex and it generates so much of data, so that analyzing this data requires experienced personnel, and advancement in the field of NGS are evolving rapidly, and the proper education regarding the ordering of the test, interpretation of the test. So this is also very important aspect in NGS based test. So coming to the various mutations or aberration in lung cancer, non-squamous lung cancer. So EGFR, it can be performed on FFP sections. Then cytology samples are also suitable. Cell blocks are also suitable, and there is good concordance between the primary versus metastatic sites for EGFR testing, and any of the site, be it primary site or metastatic site, can be used for testing the EGFR mutations. So in early stage lung cancer also, nowadays on the basis of ADORA trial, so EGFR mutation testing, it is recommended because we have a very effective adjuvant TKI option in form of osimertinib, which has improved the progression-free survival, and the overall survival data is still immature. So in terms of EGFR mutation testing, so there are a lot of advantages of NGS over PCR. And there was a study which showed that 48.6% of exon 20 insertion mutations, so they were identified via NGS, and they were missed by PCR. And out of 17 most common EGFR exon 20 insertion mutation variants, only 4 can be identified via PCR. So this advantage of NGS, we've been talking throughout this presentation, that with the NGS, so we can detect the known mutations also and the unknown mutations also. And this is how we make up the library, and this is how we evolve, and we get to know about the various mutations and the resistance mechanisms also. So coming to the ALK rearrangements, so ALK rearrangement, IHC is 93 to 100% sensitive. and specific as compared to fish. So there is good concordance. In fact, we had done a study in Rajiv Gandhi, and so what we found out was that initially when we were doing the ALK testing by fish, so the positivity rate was ALK positivity rate was close to 6 to 7%. And when we started to do it with ALK by IHC, so the positivity rate went up to 10.4 or 10.6%. So there was a more positive rate with the ALK by IHC. So coming to ROS1 rearrangements, so there are two methods which are routinely used for ROS1. So one is by IHC and one is by FISH. So IHC, it is used as the initial test at some of the institute, and if IHC is positive, so then we have to confirm the ROS1 positivity by FISH. So but if our ROS1 by FISH is positive, so it might be considered to confirm it with IHC, but it is not at all recommended. So coming to the BRAF mutations, BRAF V600E mutation is present in more than 50% of BRAF mutation cases. And these are the patients who respond very well to dabrafenib and trametinib. And there is the resistance generally develops via the pathway that bypass RAF, such as redirection of cell signaling via the downstream MEK1 or MEK2 kinases, and that is the reason why a combination of dabrafenib and trametinib is being used in this. And the best platform to use is the NGS platform, which should be used as a multi-gene based panels. So then coming to c-MET receptor mutations or MET exon 14 skipping mutation. So MET exon 14 skipping mutation causes in-frame deletion of juxtamembrane domain, resulting in increased stability and constitutive kinase activation, and it is seen in 3 to 4% of non-squamous non-small cell lung cancer. But if we see the sarcomatoid cancers in lung cancer in lung, so these mutations are enriched, and they are the frequency is 20 to 30%. So these are those kind of cancer. Whenever you encounter a sarcomatoid cancer or carcinosarcoma of the lung, so you should always try to look at the MET exon 14 skipping mutation. And we have drugs available for this, that is capmatinib, so which is a very effective drug for this exon 14 skipping mutation. So for MET exon 14 skipping mutation, IHC and FISH, they are not recommended. PCR, it can be used in few, but the best method is NGS, so which potentially detects many mutation, and RNA based NGS testing, so they are the most sensitive for this. So coming to the RET receptor, tyrosine kinase and RET fusion, so usually it is seen in 1 to 2% of non-squamous non-small cell lung cancer, and they are very prevalent in papillary thyroid carcinomas, and they happen to have 10 to 20% of these cancers. They have RET fusions, and majority of RET fusion, they can be detected by DNA NGS, but increased sensitivity is seen with RNA based NGS. So IHC, so it is not, it should not be recommended to find out the RET fusions. FISH, in rare circumstances, it can be used, but DNA and RNA based NGS, so these are the recommended methods. And so RNA based NGS platform, so they have the highest sensitivity among all the tests, and this is recommended, and we should select a NGS panel where RNA based NGS testing is being performed for fusion analysis. So coming to NTRK fusion, so we already know, so NTRK fusion, so there is a tissue agnostic indication for larotrectinib and entrectinib for the tumor with NTRK fusions, and the same is true for the lung cancer also. And in these fusion also RNA based NGS, so they are the most sensitive one. If we are performing DNA based NGS, So we tend to miss some of the NTRK fusions. So this is the recommendation, NTRK testing if it is recommended. Fish, RT-PCR or RNA NGS. So these are the recommended one. Is there a sequencing platform available? If it is yes, so we use frontline NGS. Otherwise, we can do IHC based screening assay also. And if it is positive, we have to confirm it with the NGS based platform. And if the IHC is negative, so probably our tissue is negative for NTRK fusion. So IHC can be used as a screening tool, but otherwise the confirmatory tests are FISH, RT-PCR, and NGS. So coming to the HER2 mutation in non-small cell lung cancer, it is present in 3 to 5% of NSCLCs adenocarcinomas, mostly exon 20 in frame insertions. So they are mutually exclusive with other mutations, and these HER2 mutations or amplification, so they are associated with worse overall survival as compared to the other genetic aberrations. So these should be identified using an NGS DNA-based panel and IHC. They can be used for assessment of HER2 overexpression, but mutation we will not be able to assess with IHC. And in fact, the IHC positivity has to be confirmed with a FISH or with a NGS. So because sometimes in non-breast cancers, so HER2 overexpression, it is not uh, having that much of predictive role as compared to the breast cancer. And these cancer, they need to have HER2 amplification to have a good responses to HER2 targeted therapy and a good outcome out of it. So these are the 2022 treatment paradigm, and we have to test at least these 8 markers, and the therapy has to be selected according to the marker which comes positive. For EGFR, we have osimertinib, which is the preferred one. For uncommon mutation also, so if it is exon 20 insertion, so either amivantamab or mobocertinib. And if uncommon other mutations, so which are drug sensitizing mutation, either osimertinib or afatinib can be preferred. For ALK, the third generation alectinib or lorlatinib, these are the preferred agent. For ROS1, crizotinib or entrectinib can be used. BRAF, dabrafenib, trametinib. NTRK fusions, entrectinib or lorlatinib. So then RET fusion, selpercatinib or praseltinib. Metexon 14 skipping mutation, either capmatinib or tipotinib can be used. And KRAS G12C, we already have sotorasib approved for the same. So regarding the PDL1 expression, we know so there are 4 antibodies which are there with us. So one is 22C3, which is basically performed on DACO, SP263, which is the Ventana platform, SP142 again Ventana, and 28.8, which is again a DACO platform. So these are the companion diagnostics for different immune checkpoint inhibitors. For pembrolizumab, it is either 22C3 or 28.8 in GI cancers. For SP263 durvalumab, SP263 is the companion diagnostics, and for atezolizumab, SP142 is the companion diagnostics. But as far as the lung cancer is concerned, so we have seen in the blueprint project that these antibodies are can be interchangeably used for different drugs, and they have good concordance among each other. So a different scoring system is adapted depending on the antibody used to detect PDL1. So I'll not go into the detail of it. So the biomarkers for immunotherapy in non-small cell lung cancer, PDL1 we have discussed, and it is the most important biomarker. And so we've been using it since last few years, and we have seen good concordance with the predictive role of PDL1. So TMB, it's nowadays it is used as a tissue agnostic marker, and high TMBs, so the chances of immunotherapy working is more as compared to the low TMBs. So MSIH or MMR deficient tumor, so they have good role of immunotherapy in treatment of various cancers. LAG3, so it is a possible resistance marker to immunotherapy. And so nowadays, when we are having so many compound mutations, so getting these mutation like keep mutation, lag mutation, so they sometimes guide us. So whether to use immunotherapy as the primary modality, or at least use immunotherapy along with chemotherapy if you have lag or keep mutation in the tumor. So where the PDL1 expression is on the higher side. So this is something which we get to know from the NGS panels or comprehensive genomic panels. So to conclude, biomarker testing in non-small cell lung cancer has evolved over from single gene to multiplex testing, and multidisciplinary meetings help in better understanding of the sample and test requirement. The sample should contain at least 10% of the tumor content to prevent delay in the processing. An ideal TAT has to be 10 to 14 days, and high throughput platforms such as NGS can be used to screen several genes at a time to provide result within the estimated time. So these are the oncogenic targets and testing methodologies. So we have already discussed. With this, I would like to end the talk. And if there are any questions, floor is open for questions. Over to organizers.
Thank you, Dr. Praveen, and this was a very nice talk. So uh, I think going by NGS today is the method of choice, and that to multiplex which we do. So my question is to how frequently do you perform these testing in these squamous cell carcinomas?
So nowadays, I'm counseling all my patients for NGS based testings in
So
squamous cell carcinoma also, be it smoker, be it non-smoker.
So
So
irrespective of
irrespective of smoking status.
smoking status, right? Because many of the mutations they are now being detected in squamous cell carcinomas as well.
So
That is very, very clear.
like KRAS mutations, so G12C you tend to find in this. Then EGFR mutation also you tend to find in squamous cell carcinomas. BRAF also sometimes, and NTRK fusion TMBs. So these are something. So these are tissue agnostic. So there are 3 tissue agnostic approvals. So one is for NTRK fusion, one is for RET fusions, and the third one is for MSI H MMR deficient or TMB high. So I think these testing at least should be used in all of our patients.
Thank you so much, Dr. Praveen. And the next topic for today's talk is safety of EGFR TKI. Which one to choose, and this I am going to present. So we'll focus on stage 4 NSCLC because these targeted agents nowadays they are being used in stage 4 NSCLC, and we'll be speaking upon the EGFR mutant lung cancer. So M1A, as we know, is contralateral lung nodule or malignant pleura or pericardial effusions. M1B is single extrathoracic metastasis, and M1C is multiple extrathoracic metastasis, most commonly in brain, bone, lung, liver, or kidneys. So the adequate tissue for the histological typing, as told by previous speaker, is critical, and molecular analysis is very, very critical. Biopsy is must. All the patients with adenocarcinoma component should be tested for oncogenic driver. And these squamous cell carcinomas, as well as we have discussed in previous talk also, NGS may be used to detect a broader array of mutations for those known mutations and all the unknown mutations also, and the gene rearrangement, fusions, deletions, and SNVs. The biopsy at the time of progression sometimes may be very difficult, or patient sometimes doesn't allow for the biopsies, and hence here is the role of liquid biopsies at the moment. And this is the current treatment for the metastatic disease as guided by the molecular targets. If there is no molecular target, the chemotherapy is the treatment of choice. If there is molecular target such as EGFR, ALK, or ROS1, the targeted therapy is used, and this has changed the treatment paradigm and have become the mainstay in the treatment of metastatic non-small cell lung cancer with oncogenic driver mutations and high PD-L1 expression. Survival, it has increased from 8 to 12 months to 38.6 months from the era of chemotherapy to now the era of EGFR inhibition by osimertinib in the FLORA trial. And these are all the mutations which we have already discussed in the previous talk. EGFR, MET, HER2, ROS1, BRAF, RET, NTRK, PIK3, and MAC1. These are the mutations which now have found their companion treatment available. And these are the at least the mutation which should be tested for our NSCLC stage 4 patients. EGFR sensitizing mutations, we have 5 different drugs: osimertinib, gefitinib, erlotinib, afatinib, and decomitinib. So what is EGFR mutation? These mutations, they are either categorized as deletions, insertions, point mutations, and are described as common or uncommon. Deletion refers to the mutation caused by the loss of sequence of DNA, and the insertion mutations are caused by the additional sections of DNA being added. The point mutation occurs when the single DNA has changed the sequence. So the EGFR mutation happens to be in exon 18, 19, 20, and 21. So exon 18 point mutations, they are detected in 1.85% patient. Most common mutation is exon 19 deletion, which is present in 46% patient. Second most common is exon 21 point mutations L858R, which is present in 37.5% patients. Few of the patients, they will have L861Q, which is seen in 1.1% patient. And very few number of the patients, around 4 to 5% patients, will have exon 20 mutations as well. So EGFR mutation as an oncogenic driver, they are detected in approximately 50% of the Asian population and 10 to 20% of the Caucasian population with non-small cell lung cancer. And for India, the EGFR mutation positivity rate is to the tune of 25 to 30% in the various studies from India. And the most common mutation found in EGFR is exon 19, 42 to 50%, and L858R point mutation in exon 21, which is to the tune of 32 to 42%. For patients with advanced NSCLC harboring exon 19 or L858R, EGFR TKI, they are used as a first-line therapy, as we have discussed previously also. And EGFR mutations other than exon 19 and L858R are considered as uncommon mutations. So this is the history of the development of EGFR TKI, starting from 2004 to 2017, when the osimertinib was allowed for the treatment of EGFR mutant NSCLC, which is generation 3 EGFR TKI. It all started with the discovery of the somatic mutation in the TKI domain of the EGFR in the patient with NSCLC, with the response to gefitinib in 2004, and then multiple studies with gefitinib in the form of IPA study, or with erlotinib in the form of BR21 study, Lux lung studies, AURA, FLORA, and multiple studies which led to the approval of the multiple drugs at different point in time. Today's topic is to consider the safety and efficacy of these EGFR TKI, which we have already discussed. These are 5 in numbers: erlotinib, gefitinib, decomitinib, and osimertinib. So this is the Lux Lung 7 trial, afatinib versus gefitinib. You can see that the curve started to separate only about 12 months after the patient were in the treatment. Archer 1050 decomitinib versus gefitinib, the curve started to separate after 6 months of the treatment. And with the FLORA trial, osimertinib, you can see that the immediate suppression of the curve was there. One more important thing is that the stable brain mets were included, and around 19% of the patients in the FLORA trial had stable brain mets, while the Archer 1050 excluded all the patients with brain metastasis. We have to make a caution here because cross-trial comparison without head-to-head comparative studies are there. But this is the broad idea about the quality of the drug we are talking about. And this is head-to-head comparison of various drugs. In CTONG trial, erlotinib versus gefitinib. Erlotinib gave around 13 months of PFS. Then the WJOG 5108 phase 3 trial, the erlotinib was 10.0 months of PFS. Similarly, afatinib with gefitinib comparison, the PFS was 11 months versus 10.9 months. Dacomitinib, the PFS was 14.7 months versus 9.2 months in the gefitinib arm. Similarly, the osimertinib in the FLORA trial had shown 18.9 months of PFS compared to 10.2 months of PFS with the gefitinib or erlotinib. Important thing that the brain metastasis, they were included in the osimertinib clinical trial. So PFS is a direct measure of drug benefit, immediate separation of PFS, Kaplan-Meier curves in the FLORA study. Osimertinib provided unprecedented improvement in PFS, 18.9 months across the mutations in the FLORA trial, which has hazard ratio of 0.46. Coming on to the safety. So these are 5 different drugs which are approved. The gefitinib and erlotinib are reversible binder, while the afatinib, dacomitinib, and osimertinib, they are covalent binder, and irreversible binding happens with the tyrosine kinase domain. These are the clinical targets on which these drugs act. T790M is scattered only by the osimertinib. Recommended daily dose 250 mg for gefitinib, 150 for erlotinib, 40 mg for afatinib, 45 mg for dacomitinib, 80 mg for osimertinib. And the bioavailability is 59% for gefitinib, 60% for erlotinib. Absolute human bioavailability is unknown for afatinib, 80% for dacomitinib, and 70% for osimertinib. This is the molecular structure of these first, second, and third generation oral TKI. So this is a very, very important graph, which shows the first and second generation EGFR TKI. They have high affinity to wild type EGFR. And you can see that the osimertinib has less of affinity for the wild type EGFR, while it has more affinity for T790M mutations. Similarly, you can see that gefitinib and afatinib, they do not have much of affinity for T790M mutation. And this is the reason why EGFR TKIs such as gefitinib and afatinib, they tend to have more of side effects because of the more affinity to the wild type EGFR. And this is the side effect profile. In the red, we will discuss about the most common side effects. For gefitinib, they are elevated transaminitis, that is ALT and AST levels, and the ILD events in 2 to 5% patients. For erlotinib, it is diarrhea. For dacomitinib, it is diarrhea and stomatitis, which is found in 87% patient, and 44% patient, they will have stomatitis. For osimertinib, there are 4% patient who will have ILD events. So the second generation EGFR TKI lead to higher frequency of adverse events that are associated with pan inhibition of ERB, such as rash and diarrhea. Then first and third generation oral TKI. EGFR TKI include rash, induced rash, diarrhea are usually mild to moderate in severity, but their frequency as grade 3 can vary among the EGFR TKI. For example, it appears to be higher among the patients treated with afatinib and dacomitinib compared to those with the gefitinib, and lowest is with the osimertinib. In case of rash, the erlotinib and gefitinib, the frequency of grade 3 rash appears to be higher amongst patients treated with erlotinib than those treated with gefitinib. The difference is possibly attributable to the pharmacological properties between two drugs. The administration of erlotinib at the approved dose of 150 once a daily gives rise to steady state plasma trough concentration, that is 3.5 times that of gefitinib administered at its recommended doses. The reason for liver dysfunction, transaminase and ALT and AST being more frequent among the patients treated with gefapixant compared with those receiving other EGFR TKI, it remains unclear. And this is the safety data of Archer 1050 and Flora. You can see that in Archer 1050, the dacomitinib, the number of patients who had diarrhea was 87%. This is all grade diarrhea. Paronychia 61%, dermatitis, acneiform 48%, stomatitis 44%, and dry skin 27%. Similarly, if you see for gefitinib, the 39% patient they had 39% patient they had increased ALT, 36% patient had increased AST. Just a second. Sorry. So diarrhea 56% for gefitinib, paronychia 20% for gefitinib, dermatitis acneiform 29% for gefitinib, stomatitis 18% for gefitinib. So adverse event of any grade, they were much higher with dacomitinib in Archer 1050 as compared to the osimertinib in the Flora trial. This is the tolerability profile of EGFR TKI. We are discussing about grade 3-4 side effects with afatinib, dacomitinib, and osimertinib. You can see diarrhea is very common with afatinib. Grade 3-4 diarrhea is to the tune of 14%, and it is to the tune of 8% by dacomitinib, while it is 2% with osimertinib. Acneiform rash 16% with afatinib, 18% with dacomitinib, and 1% with osimertinib. Stomatitis, mucositis 9%, afatinib 3.5%, dacomitinib 1%, osimertinib. Paronychia 11%, 8%, and 1%. Adverse event, all grade 3 events are 49% in afatinib, 63% in dacomitinib, and 18% treatment-related adverse events in the osimertinib. And adverse events leading to the dose modification, if you see, 66% of the patients they had to dose modify in the dacomitinib arm in the Archer 1050 trial. 52% patient in the afatinib arm in the Lux Lung 3 had dose modification, while 4% patient in the osimertinib arm had dose modification because of the adverse events. Second generation EGFR TKI, they have unfavorable toxicity profile. Grade 3 above adverse events are much more higher with dacomitinib. This is the same safety data that we have already discussed in the previous slide. Grade 3-4 adverse events with dacomitinib were reported in 63% patients in Archer 1050. Coming on to the dose reductions. So any adverse event leading to the dose reduction was 66% in the Archer 1050, while you see any adverse event leading to dose reduction was 2.9% in Flora trial. Any adverse event leading to death, 2% in the Flora trial, while any adverse event leading to death in Archer 1050 was 10% in the Archer 1050 in the dacomitinib. So dose reductions, 66% in Archer, 3% in Flora. Serious adverse events, 27% in Archer, 4% in Flora. Adverse event leading to death, 10% in Archer and 2% in the Flora trial. So as the first line treatment, second generation EGFR TKI leads to higher frequency of adverse events that are associated with pan inhibition of ERB2 such as rash, diarrhea, than the first or third generation EGFR TKI. If adverse event severity does not lessen or cannot be managed, dose of EGFR TKI should be reduced. Dose adjustments are more frequent with second generation EGFR TKI and they're less frequent with the third generation EGFR TKI. Osimertinib is considered to be well tolerated at its recommended doses, that is 80 milligram. And the management scheme states that 40 milligram dose may be given under certain circumstances. Patients with osimertinib report fewer higher grade adverse event compared to standard of care EGFR TKI, such as erlotinib and gefitinib. And patients receiving second generation EGFR TKI are more likely to require dose reduction due to adverse events. So dependent upon the adverse event duration and severity, dose modification of second generation EGFR TKI may be necessary to improve the tolerability. Dose reductions due to adverse events. So this we have already discussed in the previous slide. So Lung-7 dose reduction were more frequent with afatinib compared with gefitinib, that is 52% versus 1.9%. Archer 1050 dose reductions were 66.1% were reported. 38.3% patients receiving dacomitinib, they had dose reduced to 30 milligram, and 27% patient had to dose reduced to 15 milligram. That is the lowest possible dose. The median time to first dose reduction for the dacomitinib was 2.8 months. And these data suggest that dacomitinib is often intolerable at starting dose of 45 milligram per day. This is the safety post-hoc analysis of the effect of dose reductions. So the post-hoc analysis on the effect of dose reduction found that the median PFS in the patients with dacomitinib who had dose reduced was 16.6 months versus 14.7 months who were treated with the full dose. Median overall survival was 36.7 months versus 34.1 months who were treated with the full dose. And overall response rates were more, that is 79% versus 74% for those patients who had not dose reduced. So the dose reduction resulted in lower incidence and severity of grade 3 adverse event. However, even after dose reduction, the incidence is much higher as compared to the osimertinib in the FLORA trial. Also, this is important that this was post-hoc analysis, and post-hoc analysis are an issue because they conform to neither the population nor the randomization model of the statistical inference. And when we discover an apparent difference by unplanned post-hoc analysis, we may have discovered nothing but more than a simple coincidence. Coming on to the quality of life. So the Lung-7 compared afatinib to gefitinib and showed that there was similar improvement in quality of life with both the treatments. Archer 1050 showed that overall quality of life improved significantly from baseline in the patients treated with gefitinib rather than dacomitinib. In the FLORA trial, osimertinib showed a consistent trend toward better improvement across scores compared with the gefitinib. However, none of these scores reached clinical significance, so no conclusion can be drawn. These are the data for the quality of life in the Archer 1050 and the FLORA trial. Global quality of life was maintained in the dacomitinib group and was significantly improved in gefitinib group. While in FLORA trial, the quality of life was improved from the baseline in both gefitinib and EGFR TKI comparator group, with no clinically relevant difference between the two groups. Global quality of life significantly worsened in the dacomitinib group versus gefitinib group. Remember, one of the treatment goals in the metastatic setting is to improve quality of life of the patient. Second generation EGFR TKI worsen the quality of life of these patients, which is totally unacceptable in the metastatic setting. These are the data for quality of life. Coming on to the management of the adverse events, that is acneiform diarrhea, acneiform rash, and diarrhea. So these are the incidence of skin and GI events with EGFR TKI and NSCLC for different drugs. The most commonly, the rash or acne are caused by afatinib, followed by erlotinib, and then gefitinib. Similarly, the pruritus and dry skin are caused by gefitinib and afatinib, and lesser number of the patients in osimertinib arm will also have some dry skin or pruritus or rash. Similarly, diarrhea, if you see 95% in the afatinib treated patient, 46% in the gefitinib treated patient, and 21% in the erlotinib treated patient, 41% in the osimertinib treated patient. So these are the form of rash, grade 1, papulopustular rash, that is acneiform rash, which covers less than 10% of BSA. Grade 2, the BSA covered is 10 to 30%. Grade 3 rash, the BSA more than 30%, erosions, vesicles and desquamation may be present. And grade 4 is BSA more than 30% covered, blistering, erosions, ulcerations, epidermal degeneration may be present in these patients. Coming on to the management of the skin rash. So grade 1, continue oral TKI, a topical anti-inflammatory antibiotic such as clindamycin 1% lotion can be used. Topical corticosteroid may be used if it is itchy. Grade 2, continue the treatment. If intolerable, then interrupt. And oral anti-inflammatory antibiotics for at least 6 weeks, such as doxycycline twice a day or minocycline twice a day. Clindamycin 1% lotion BD, and here the oral prednisolone may be considered for 5 to 7 days. If it is grade 3, interruption of oral TKI is important and consider refer to the dermatologist. Resume TKI at the reduced dose if the patient recovers to grade less than equal to 2. If infection is suspected, then anti-staph antibiotics such as cloxacillin and ceflexin for 7 days. Consider bacterial culture, potassium permanganate, and topical corticosteroids with antimicrobial combinations. Grade 4 rash, interrupt TKI, refer to the dermatologist and may need the admission to the dedicated burn unit or skincare unit. Coming on to the diarrhea, grade 1 diarrhea is increase of stools less than 4 per day. Grade 2, 4 to 6. Grade 3, severe increase of 7 or more. Then grade 4 is life-threatening. The TKI-induced diarrhea, the management strategy, the most cases are uncomplicated grade 1 and grade 2 diarrhea and can be easily managed with the help of loperamide, diphenoxylate, atropium, or resicarotil. For grade 3 and 4 diarrhea, it is important to be managed more aggressively with the help of treatment interruptions and reinitiation at the reduced doses with the IV fluids, antibiotics as needed to reduce the life-threatening side effects. So grade 1, 4 milligram of loperamide immediately after symptom began and 2 milligram after each stool until there are no bowel movement for 12 hours, maximum 16 milligram a day. Grade 2, similar, assess for hydration and electrolyte imbalance. Grade 3, hospitalization, continue loperamide and aggressive intravenous fluids. For adverse event, grade 3, withhold the treatment up to 3 weeks. If the reaction improves to grade 0 to 2 within 3 weeks, resume at 80 milligram or 40 milligram. If does not improve within 3 weeks, permanently discontinue the treatment. So coming on to the conclusion, second generation EGFR TKI, afatinib, dacomitinib are burdened by the toxic profile. Adverse events leading to the dose reduction in Archer and Flora are huge. Grade 3 or above adverse events reported in more than 63% patients. Also, the dacomitinib deteriorates the quality of life of these patients. On the other hand, we have already approved third generation osimertinib with a far more better clinical safety profile, be it efficacy, tolerability, or CNS activity and quality of life. So these are NCCN guidelines, current guidelines for EGFR sensitizing mutation. We have preferred agent osimertinib, which is category 1. Other agents are also category 1, but they are not preferred agent. Takeaway points. The FLORA trial of EGFR positive NSCLC must be taken as reference in the era of precision medicine, showing a statistical and clinical significant improvement without any concerns related to the toxicity profile and a very high activity of this brain metastasis, reducing the comfortless role of the whole brain, discomfortless role of whole brain palliative radiation. On the other hand, second generation TKI, they are burdened with the toxicity profile and poor quality of life. Archer 1050 also excluded the patient with brain metastasis, failing to provide the fundamental information in the drug evaluation process, especially for NSCLC that often progress in the brain. On the right hand side, you can see the PFS of the osimertinib, which is 18.9 months, while for dacomitinib it is 14.7 months. Overall response rates around 77%, 75%. Duration of response more in osimertinib compared to dacomitinib. Overall survival 38.9 months versus 34 months. And safety profile we have already discussed in previous slides. Thank you so much for your patient listening. This is the prescribing information for osimertinib. The floor is open for any question and answer.
So, Dr. Manish, I have one question.
Yes,
So,
doctor.
regarding the brain metastasis with EGFR mutation, so it's always a tricky kind of discussion. So those patients with minimal symptoms, multiple brain metastasis, if you go ahead with radiotherapy, it is going to be whole brain radiotherapy. Then you have the result of EGFR mutation and it is exon 19 deletion. So do you really go ahead with radiotherapy followed by EGFR directed therapy, or you directly go ahead with EGFR directed therapy if patient is eligible for osimertinib?
So if patient is eligible for osimertinib, we have already seen in the clinical trial the patient who have stable brain metastasis with no sign and symptoms of.
No, but the patient is minimally symptomatic for the brain metastasis.
See, if there are symptoms, then I go for radiotherapy followed by osimertinib. So the important thing is that patient must not be symptomatic.
No, I totally agree, because these scenarios where the patient is minimally symptomatic, so I know in the trial setting you cannot take those patients. So, but in so now I'll present the real world data of osimertinib, and there they have taken this kind of patient, and we have seen in our clinical practice also. So that if patient is minimally symptomatic with a frequent CNS monitoring, I think we can go ahead with osimertinib also, and it has got a CNS response rate of close to 70%. So that is the response rate which we achieve with the radiotherapy also. So I think this is something which is very, very important, that we can, if a patient is minimally symptomatic, stays nearby our hospital, will follow the guidelines, will follow our guidance. I think with a narrow like monitoring window, we can do osimertinib also. Like we can perform a MRI after 2 months, or if a patient is deteriorating, then we can perform an MRI and we can go ahead with the radiotherapy. I know guidelines doesn't recommend this, but uh, this kind of thing we are doing in our clinical practice. I think Dr. Manish has got disconnected.
Oh, I am here.
So you are here.
Yes. So I think the real world evidence is there, and you will be presenting the real world evidence of osimertinib. I invite Dr. Praveen to present the real world evidence of osimertinib in EGFR mutant NSCLC.
Thank you, Dr. Manish. So I hope my screen is visible.
Yes, Dr. Praveen.
So I'll quickly take you through the real world evidences of osimertinib. We know that osimertinib, it has already become an established therapy, be it first line EGFR mutated non-small cell lung cancer, or second line non-small cell lung cancer with EGFR mutation, or in the adjuvant setting. So, but there are certain scenarios so which are not included in the randomized control trials. So almost 3 to 5% of the patient, they are only candidate for these randomized control trial. So randomized control trial population is not exactly corresponding to the real world population. So that is the importance of these real world evidences. So in patients with EGFR mutations, PFS improves after treatment with EGFR TKI compared with that of cytotoxic chemotherapy, and we have seen it in clinical trials of first generation TKI, where these EGFR TKI, they were compared against the chemotherapy. And after establishing the role of EGFR targeted therapies, so second generation TKI, there are few trials which compared against the cytotoxic chemotherapy, but the later trials, so they compared against the first generation TKI. And we know osimertinib, which is a irreversible third generation EGFR TKI, so it was compared against first generation TKI in the phase 3 randomized FLORA trial, and it has shown the improvement in median progression-free survival, where the median PFS with osimertinib was 18.9 months, and it was 10.2 months with the EGFR first generation TKI. So recently, the overall survival advantage of osimertinib was also showed in the mature analysis of this trial. So the median OS with osimertinib was 38.6 months versus 31.8 months with the first generation TKI. And these data, Dr. Manish has already alluded to. So this was the FLORA schema. Dr. Manish has already taken care of this. And OS was a key secondary endpoint for this trial. And these were the baseline characteristics. I'll not go into the details of these things. But one thing which I want to highlight over here is that the CNS metastasis at study entry. So these were close to 20% in the FLORA trial. Okay. And if we see the EGFR mutational status, so 2/3 of the patient, they had exon deletion 19 mutation, which is considered to be a better mutation, better like more sensitive mutation as compared to L858R. And these two things I would like to highlight over here. And with this was the final overall survival analysis of FLORA. So where osimertinib had a median OS of 38.6 months, and it was 31.8 months with the first generation TKI. It was statistically significant with a hazard ratio of 0.799. So the conclusion of this trial was that it had a median progression-free survival, median overall survival advantage. Apart from that, there was a CNS response rate which was in favor of osimertinib, and there was a CNS PFS which was in favor of osimertinib. So the guidelines also recommend osimertinib as the preferred agent in the first line systemic therapy for EGFR mutated non-small cell lung cancer. So coming to the real world evidences of osimertinib, so they are important in their own aspects. So because they include those population which are not the trial population. So like those patients who are very elderly, those patients with a poor performance status, those patients who have multiple comorbidities, those patients with Charlson's index, higher Charlson's index, those patients with untreated brain metastasis or symptomatic brain metastasis, as we were discussing. Just a second.
Dr. Praveen? Hello? Hello? Hello?
हेलो सर सर शायद सर का ना नेटवर्क इशू है कुछ
अच्छा ठीक है So I'll be talking about the real world evidence of osimertinib, and I'll be talking in particular about 3 studies. So one is the FLOWER study, then is the OCFACT, and then is the Mykonos study. So we will see one by one. So the flower study, it was the first line osimertinib in patient with EGFR mutated non-small cell lung cancer. So, it has been estimated that only 2 to 4% of patients with cancer, they receive treatment within randomized controlled trial, thus raising the issue of representativeness. And it is seen that the trial population is not exactly the representative population when the whole population is considered. And the real world data, they have become useful tools to assess unique insight in routine oncology practice in the post-marketing setting. So these are the baseline characters of this study. And we can see over here, like I highlighted in FLORA trial, so the brain metastases were present only in the 20% of the population. But this is the exact number which we have seen in the real world, that 30% of EGFR mutated patients, so they have baseline brain metastasis. So again, coming to another point, which is the stage at diagnosis. So almost 95% of the patients, so they were having a stage 4A, 4B disease. However, if we see the FLORA trial, most of these patients, they were of stage 4B, and almost 5% of the patients, they had stage 3B or 3C disease. Another important point is that in the FLORA trial, so the exon 19 deletion, so those were enriched and those were approximately 65% of the patient. However, in this trial, so it was 50% and 44%, and the other uncommon mutation and the complex mutation also were involved in this trial. So these are the few differences in the baseline characteristics of this real world study as compared to the FLORA. So the inclusion criteria of this study was that they had included those patients with more than 18 years of age with a histological or cytologically confirmed diagnosis of non-small cell lung cancer. And these patients should have to have EGFR mutation, drug sensitizing EGFR mutations. So in exon 18 to 21. Then locally advanced recurrent or metastatic stage 3B or 4 tumors were included, and these patients should have been eligible to receive first-line treatment with the third-generation EGFR TKI osimertinib. And the only exclusion criteria for this trial was that those patients who received the study drug in clinical trials, so they were excluded. Rest of the exclusion criteria were not there. And the primary endpoint of this trial was median time to treatment discontinuation. So this is an endpoint which is under exploration for the real world study to and this is defined as the time. This is defined as the time from the osimertinib start to discontinuation because of any cause. So it could have been the death, it could have been because of intolerability, or it could have been because of any other thing. The second primary endpoint was the rate of treatment-related adverse events. And the third endpoint was the rate of dose reduction and temporary or definitive treatment interruption because of the adverse event. So these were the primary endpoint, and the secondary endpoints were median overall survival, median progression-free survival, the overall response rate, the disease control rate, then the progression patterns to osimertinib in terms of number and localization of metastatic sites, new lesions, and progression-related symptoms. So there was a diagnostic therapeutic pathway also which was studied. So which was the time frame between the diagnostic biopsy and the histologic report. So the proportion of patient who underwent locoregional treatment, the type and frequency of rebiopsy performed at progression. So these were the diagnostic therapeutic pathway. So these were also studied. And if we see the primary assessment, which was related to the effectiveness of the drug, so those patients with poor performance status, comorbidities, rare EGFR mutation, and active brain metastasis, they were also included in this trial. So these patients were excluded in FLORA trials. The outcomes were similar to the published data, thus adding consistency to the osimertinib efficacy. So there were no difference in the progression-free survival, time to treatment discontinuation, and overall survival, which were noted in elderly patients, and they did fairly good corresponding to the same outcome which was seen in the adult population. Patient with comorbidities and less common EGFR mutation also the progression-free survival, the time to treatment discontinuation and overall survival were differences were there. So if we see these Kaplan-Meier curves, so we can see over here that the time to treatment discontinuation was median time to treatment discontinuation was 25.3 months. And if we see in those patients who had no symptoms, so this above line is those patients who did not had any symptoms, and this is the patient who had symptoms. So those patients without symptoms, so the median time to time to treatment discontinuation was not reached till the time of follow-up period. And if we see the median TTP in those with symptoms, so it was 18.8 months. And if we see according to the number of the metastases, so less than 3 metastases, again, medium TTP was not reached and TTD was not reached. And if we see in more than 3 metastatic site, so the median TTD was 21.4 months. So these were the factors so which were very important, like whether the patient was having symptoms and more than 3 sites, so they were more prone for progression or treatment discontinuation as compared to those with less than 3 sites and no symptoms. So time to treatment discontinuation appears to be a more suitable endpoint to evaluate treatment outcome in pragmatic real world trials. And the TTD was longer, 25.3 months than the post progression outcome analysis of FLORA trial, which showed 20.8 months, probably due to study population was unfit for further therapy or different therapy for oligoprogressive disease. So better TTD was associated with fewer than 3 progressing sites and oligometastatic progression as compared to the systemic progression. So if we see the multivariate analysis for PFS, overall survival and time to treatment discontinuation, we can see the presence or absence of the symptoms. So this was the most important factor which led to differences in PFS, OS or time to treatment discontinuation. So the other factor was less than or more than equal to 3 sites, which was again significantly influencing the PFS, OS, and time to treatment discontinuation. And the presence of brain metastasis or absence of brain metastasis was significantly influencing the PFS, median PFS of the patient. So if we see at a median follow-up of 12.3 months, the median PFS of osimertinib was 18.9 months. And if we see the responses which were achieved with the osimertinib, the complete response was seen in none of the patient. The partial response was seen in 73% of the patient. The stable disease was seen in 23% of the patient. And only 4% of the patient progressed when started on osimertinib. So coming to the PFS analysis, we can see over here that the median PFS was 18.9 months. And if we see the PFS according to the presence or absence of brain metastasis, so the PFS with no brain metastasis had not reached, and with brain metastasis it was 13.3 months. So the median PFS in patient with or without brain metastasis diagnosis, we can make out over here. Those patients with no brain metastasis, they have better median PFS as compared to those with brain metastasis at presentation. So coming to those with no symptom versus symptoms, again, no symptoms, the median PFS was not reached. With symptom, it was 15.5 months. So these symptoms, brain metastasis less than or more than equal to 3 sites. So these are very important factor that influences the median PFS also and median time to tumor treatment discontinuation also. So on multivariate analysis, the longer PFS was noticed in the absence of brain metastasis, and the prolonged PFS and longer OS also was noticed in patient without symptom at diagnosis. And time to treatment discontinuation of 9 months or higher, it was significantly associated with better overall survival with a hazard ratio of 0.145. So this suggests that those patients who initially did good on osimertinib, So they had a better outcome, and probably it is almost corresponding to the duration of response. So regarding the real world diagnostic therapeutic pathways, so among patients who experience progressive disease, so there were 44 such patients. So 21 cases, they underwent a rebiopsy at progression. So 14 patients, so they had tissue rebiopsy, and 6 patients, they had liquid biopsy. And the molecular analysis was performed in 13 of these samples. And the druggable resistance mechanism, it included the following. So one was the MET amplification, which was seen in 4 patients. So MET amplification along with EGFR amplification was seen in 1 patient, EGFR amplification in 1 patient, and HER2 amplification in 1 patient. So these were the analysis of resistance mechanism which were analyzed in these samples. So coming to the safety data and conclusion, we can make out over here that almost 87% of the patient, they had some side effect, some adverse events. So the most common adverse events were the diarrhea, rash, dry skin, and paronychia. And but the most peculiar ones were the interstitial lung disease or pneumonitis, which was seen in 9.5% of the patient, and out of which 2.5% they were grade 3 or 4, which literally troubled the patient. If we see the venous thromboembolism, it was seen in 9.5% of the patient, and 7.9% of the patient, they had grade 3 4 venous thromboembolism. So again, a very different thing, so which was not seen in the FLORA trial. So that was the creatinine increase. So it was seen in almost 20% of the patient, and then it was asymptomatic creatinine increase, and there were no grade 3 or 4 creatinine increase with the osimertinib. So rest of the adverse event profile, so they were less than 2%. So this is the crux of it. 87% had some adverse event and 33% had grade 3, 4. VTE was the most common adverse event with 7.9% as the frequency. In the real world ESTRIS study, grade 3 pulmonary embolism. So pulmonary embolism is always considered as grade 3 venous thromboembolism. It accounted for 2% of the pre-treated patients receiving osimertinib. So there was no differences in the rate of venous thromboembolism, which was reported according to the age, performance status, Charlson comorbidity index, and the tumor load. So these were not influencing the rate of venous thromboembolism. So we can see over here that the values are statistically insignificant. However, so there were some numerical differences in these categories. So there was no difference in survival outcome, which was observed according to the age, comorbidity, and type of EGFR mutation. Osimertinib confirmed effectiveness and safety in the real world scenario. So coming to the second study, which is the osimertinib as first line treatment for advanced epidermal growth factor receptor mutation positive non-small cell lung cancer in the real world setting, which is the OSI-FACT study. And this study was published in 2021. So this study investigated the differences in efficacy with the patient background and the safety of first-line osimertinib treatment in the real-world scenario. So the inclusion criteria, so the only inclusion criteria was that EGFR mutated non-small cell lung cancer with osimertinib as the initial treatment. And the exclusion criteria were patient concurrently using any other anti-cancer therapy or radiotherapy, undergoing post-operative adjuvant chemotherapy, receiving osimertinib as the second line treatment, they were excluded from the trial. So again, coming to the baseline characteristic, again we can make out over here that the 50% of the patient, they were having exon deletion 19 and 45% had L858R. So another thing is the presence of brain metastasis, which was seen in almost 30% of the patient, out of which 6% were symptomatic and 25% were asymptomatic. And these patients also had 3% of the patient also had leptomeningeal diseases. So the primary endpoint of this trial was progression-free survival, and the secondary endpoint was overall survival, time to treatment failure, response rate, and the objective response rate and disease control rate. So if we see the efficacy analysis, the PFS events occurred in 182 patients and the median PFS was 20.5 months. So the parameters which were significantly associated with PFS, they were male gender, malignant effusions, liver metastasis, and advanced unresectable disease. So these were associated with the PFS analysis. So with respect to PDL1 expression, median PFS was not reached in patient with the TPS of less than 1%, 14.7 month with a TPS of less than 49%, and 11.1 month for those with TPS 50%. And it was not reached in the patient with TPS unknown. So there was not any pattern which we could make out from the PDL1 expression. The only thing was that more the PDL1, the lesser was the PFS. So which is something which I cannot explain on the basis of any logic. So coming to the primary endpoint, which was the PFS. So we can see over here, so that the male, so they have better PFS with osimertinib, and probably the control arm was the historical control of first generation TKI. And if we see the other parameters like PDL1 of 1 to 49, again it was statistically in favor of osimertinib. So in L858R again, so there was a difference in osimertinib versus the other second generation TKIs. So coming to treatment discontinuation profile, so 44.3% of the patient, they discontinue treatment because of the disease progression. 25.6% of the patient, they continue treatment because of the pneumonitis. 16% because of some other adverse event, and 14% because of the progression of disease. So this is something which is not in line with the FLORA trial, that almost 40% discontinuation rate because of the adverse event, be it pneumonitis or be it some other adverse event. So this was not highlighted in the FLORA trial. So this is something worth noting. So again, they also have enumerated the adverse events: anorexia in 8 patients, skin disorder in 7, cardiac failure in 4, QT interval prolongation in 3. Then there are other fatigue, anemia, thrombocytopenia, leukopenia, hyponatremia, so which led to 2 or 1 patients leading to discontinuation. So this is something which we definitely have to look for. So again, the tabular form which shows that 12.8% of the patient, they had all grade pneumonitis, and 4.5% of these patients, they had less than equal to grade 3 pneumonitis, and 5%, 0.7% had grade 5 pneumonitis. And the median duration of onset of pneumonitis was 56 days. If we see the QT interval prolongation, so it happened in 4.1% of the patient, and 3% of the patient, they were more than equal to the grade 3 side effects. So reduced ejection fraction or heart failure, it was seen in 1.5% patient, and all adverse event leading to treatment discontinuation was 16.9%. So the conclusion of this trial was that the overall response rate with osimertinib was 76%, and the disease control rate was 94%. And the progression-free survival was better with osimertinib as compared to the conventional EGFR TKI. So median time to median TTF was 19.1 month, and the median time from the start of treatment to the onset of AE was 56 days. The pneumonitis of all grades occurred in 69 patients, and 4.5% of the patient had grade 3 or higher pneumonitis. And fatal pneumonitis happened in 4 patients. So to conclude, the PFS after first-line osimertinib treatment in real-world practice was favorable, and the discontinuation rate due to AEs were 18.8%, especially pneumonitis, which requires further investigation. And the last study is this study. So the here this study, it reported the demographic and clinical characteristics, real world time to new treatment or death, and real world time to treatment discontinuation of patient with advanced EGFR metastatic non-small cell lung cancer. So it was studied in the US, and it was on the basis of Flatitron data. So it was a global observational prospective cohort study in US, Europe, and Asia. So they had included the data from the nationwide Flatitron Health electronic records, and they had de-identified the patient level structured and unstructured data, and after that they had analyzed that data. So in total, so 280 US cancer clinics, they were supposed to be enrolled in the study. And for this interim sub-analysis, data were collected through June 30th, 2020. And the study is still ongoing, and the follow-up period is planned till June 2023. The inclusion criteria were that the patient had to be more than 18 years old with advanced non-small cell lung cancer. They had to have stage 3B or 4 disease with EGFR mutation documented prior to initiation of first-line osimertinib monotherapy, and the osimertinib has to be started between April 1, 2018 to March 31st, 2020. So there were these 4 windows. So the exclusion assessment window. So this here, those patients who were less than 18 and use of osimertinib within a clinical trial, so they were excluded. So then baseline covariate assessment window. So they had included clinical characteristics, biomarker testings, demographics, comorbidities, CNS imaging, and the neoadjuvant or adjuvant treatments. So after these windows, so the patient was identified in the patient identification window, and after that the patient was started on the treatment and the follow-up assessments were done, and the follow-up assessment window was from day 0 to day 1916. So the baseline clinical and demographic characteristics and treatment patterns, they were summarized using descriptive statistics. So Kaplan-Meier analysis were used to generate estimate of TTNTD and TTD. So TTNTD is time to new treatment and death, and TTD is time to treatment discontinuation. So the real world time to new treatment or death was defined as time from index date until the start of next systemic therapy or the death in absence of next systemic therapy. So this was RWTTNDT, and RWTTD is time from index date until the earliest end of osimertinib associated with discontinuation on or prior to end of first line therapy. So these were the analyses which were performed. These were the baseline characteristics. Again, we can see over here that the presence of brain metastasis was seen in 33.6% of the patient, and the Charlson's comorbidity index, almost 67% were having a Charlson comorbidity index of 0, and almost 33% or 1/3 of the patient, they had Charlson comorbidity index of 1 or more than 1. So if we see the mutational status again corresponding to the real world studies, so 50% are DEL19, 34-35% are L858R, and the uncommon mutations 9.5%, and both common and uncommon mutation 4%. So these are the treatment sequencing. At 548 patients, they were started on first line osimertinib in this trial. 103 patients, so they received second line treatment. 318 patients, so they are still on first line therapy or lost to follow up. 101 patients, they died on first line treatment, and 26 discontinued first line treatment because of some other reason. So we can see here the real world time to next treatment or death. So we can see that the median time was 17.9 months, and there were 204 events, and 101 patient had died, and the other event was switched to second line, so which was 103 patient or 18.8% patient. So if we see the multivariate analysis, we can see over here that the stage at initial diagnosis of non-small cell lung cancer, smoking status, Charlson's comorbidity index of more than equal to 3, then EGFR mutation, which are other EGFR mutation, and the number of metastatic site more than 4. So these were the 5 factors which definitely influenced real world time to next treatment or death. So if we see the real world time to treatment discontinuation, time was 17.2 months, And the in this 18% patient died, 18% patients switched to second line, and 5% patient discontinued the treatment because of some other causes. Again, on multivariate analysis, the factors which influence real world time to treatment discontinuation were the Charlson comorbidity index of more than equal to 3, an ECOG performance status of more than equal to 2, then EGFR mutation status of uncommon mutation or composite mutations, the number of metastatic site more than equal to 4, and evidence of liver metastasis. So these were the factors which influence real world time to treatment discontinuation. And the study provide real world insight into the use of first line osimertinib in patient with advanced EGFR metastatic non-small cell lung cancer. The interim real world time to new treatment and death and real world time to treatment discontinuation results supports the effectiveness of osimertinib in this real world population, and the longer term outcomes will be evaluated in the final analysis. So with this, I would like to end the talk. If there are any questions, so please go ahead.
Dr. Praveen, that was a very wonderful presentation about the real world study. So don't you think that the pneumonitis and pulmonary embolism, they were astonishing in these real world data, which we have never seen in, and similarly the rise of serum creatinine for our patients in the FLORA trial?
So means venous thromboembolism, drop in ejection fraction, myocardial infarction. So we have seen, but we do not have that many numbers so that we can see the incidence of these. So what is the rate of these? So but this is really surprising that in FLORA data, so which was the randomized trial and which has all kind of reporting which happens on priority. So they had not reported that many number of venous thromboembolism and the ejection fraction drop and the QT prolongation and the pneumonitis also. So these four side effects, which are AEs of special interest probably, I think there has to be further analysis regarding the estimates of these. So this is very, very important because we used to consider osimertinib as an entirely safe drug. So with no side effects, it's a beautiful drug because it doesn't affect the wild type EGFR. But these side effects, so how it is leading to these side effects, so this we have to definitely look at.
Yes, true. So with these real world studies, we can keep an eye on these side effects in our patients as well, because you rightly said we don't have so many numbers to suggest that these are really happening in our patients. But as far as I have my experience of osimertinib, I did not encounter these side effects except for a drop in ejection fraction for one of my patients. And touch wood, I have not encountered any pulmonary thromboembolism or myocarditis for my patient. So next, I will present the role of nutrition and protein supplements in the cancer patients. So the malnutrition and the loss of muscle mass are frequent in the cancer patients and have negative effect on the clinical outcome, driven by inadequate food intake, decreased physical activity, and metabolic derangements. And therefore, the standard operating procedures, responsibilities, a quality control process should be established at each institution involved in the treating cancer patients to screen for, prevent, assess in detail, monitor, and treat malnutrition. So this is latest global cancer data. Cancer burden rises to 18.1 million new cases and 9.6 million cancer deaths in 2018. So this is a graphical representation of the same. So coming on to the burden of the cancer in Indian population. So you see the number of newer cases, 5,70,000 in males and 5,87,000 in females. And in both sexes, cumulative number of new cases were 11,57,294. Number of cancer deaths. So more than 50% of the patients, they die of cancer. and the number is 7,84,821. Similarly, if you see the 5-year prevalence rate, 5-year prevalence rate is 22,58,000. And topmost 5 cancers in Indian population are breast, lip and oral cavity, cervix, lung, and stomach cancer. The patient with cancer have altered nutritional status at presentation, and it varies throughout the continuum of the cancer care. Most of the patients experience unplanned weight loss leading to diagnosis of cancer, and there are 30 to 85% of the patients with cancer reported with the malnutrition. And you can see that the malnutrition is reported across different specialties such as surgery, orthopedic, neurosurgery, neurology, across all the specialties of medicine. But in oncology, the prevalence of malnutrition is to the tune of 71%, which is highest amongst all the specialties of medicine. And this is the prevalence of the malnutrition in the patient at first medical oncology encountered. This is the first study, that is Premio study. And malnutrition, anorexia, weight loss are the common in cancer patients, even at their first visit to the medical oncology center. And what are the metabolic changes in the oncology patients which are happening? Because of the reflexes to the brain, there is decreased food intake because of the cytokine and cachexic factor release, such as TNF-alpha, IL-1, IL-6, interferon, and STAT3, which act on fat, leading to the increased lipolysis, acting on the liver, leading to increased nitrogen loss, and acting on the muscle, leading to insulin resistance, decreased synthesis, increased breakdown, and skeletal muscle and fat mass wasting. So, role of tumor-induced systemic inflammation with metabolic pathways, it is great. So, coming on to the factors which are associated with malnutrition, underweight at presentation, more than 5% weight loss. So, you can see that the hazard ratios are 1.6 for them, colorectal cancers 1.6, hematological malignancy 2.4. These we are talking about the ambulatory patients. For the adult patient, they are even more. Head and neck cancer patient 3.3, lung 2, upper GI 3.8, metastatic disease 1.4, chemotherapy 1.6, and chemoradiotherapy 2.3. So before hospitalization, there are some of the reasons. During hospitalization, there are some of the reasons, and after hospitalization, there are some of the reasons. So before hospitalization, poverty, local availability, meal fads, loneliness, depression, old age, tobacco use, and other factors are also there. While in hospital, there are different factors which lead to the malnutrition, such as not screening properly for the malnutrition, fear and anxiety, investigations, starvation, cachexia, treatments, different treatments leading to the anorexia, appetite, food choices, GI problem, fever, sepsis, surgery, trauma, disease, medications, nil by mouth, sedation, and GI problems. While after hospitalization, there are some of the reasons because of which the malnutrition happens, such as no definite advice on the dietary front, food fads, no supervision, loneliness, medications, depression, forgetfulness, and some other points as well. So malnutrition significantly increases the post-op morbidity, mortality, and the cost of the treatment. So pre-cachexia, weight loss less than 5%, anorexia and metabolic change, cachexia, weight loss more than 5%, or BMI of less than 20 and weight loss of more than 2%, or sarcopenia and weight loss of more than 2%. Often reduced food intake and systemic inflammation. Refractory cachexia, the variable degree of cachexia, cancer disease, both pro-catabolic and not responsive to anti-cancer treatment, low performance score, less than 3 months expected survival, and finally death. So up to 20% of the cancer deaths are because of the malnutrition or cachexia. 1 in 5 patients with cancer dies from cachexia and not from cancer. So cachexia has a detrimental consequences. And these are the reasons for the cachexia in the various patients who are being treated with radiotherapy or chemotherapy, such as reduced food, weight loss, mucositis, food aversion, taste loss, nausea, anorexia. And this is the risk of dose limiting toxicity for those patients who have muscle damage or who have decreased amount of food intake. Chemotherapy is reduced by more than 20% or terminated in sarcopenic patient due to excessive toxicity. So you can see green is the normal and red is the sarcopenic patient. Dose limited toxicity increases as we have more sarcopenia, and it is irrespective of the cancer which we are dealing with, either colon cancer, lung cancer, thyroid cancer, liver cancer, renal cancers. In all of them, the chemotherapy is reduced by more than 20% or terminated in the sarcopenic patient due to excessive of toxicity. Non-nutritional risk factors in cancer. One, severe immune suppression. Mucosal lining is often disrupted, gut motility is altered, satiety, vomiting, etc. Treatment lasts for several months, and increased treatment and associated cost. So there is a dynamic relationship between cancer treatment and malnutrition. As we induce more of the patient with very intensive chemo protocols or surgeries or radiation therapies, the malnutrition tends to increase. So cancer treatment is basically in two different things. One is cancer treatment, actual cancer treatment, and second is patient supportive care. The patient supportive care helps our patient to tolerate the treatment of the cancer well. So what are the patient supportive care? Prophylactic treatment of the side effects such as nausea, vomiting, mucositis, anemia, neutropenia, which we all do in our post chemotherapy prescriptions, pain management, psychological counseling. But we forget to stress upon the nutritional support in the post-discharge, post-chemotherapy discharges, which include oral nutritional supplements, enteral or parenteral nutrition. So nutrition is an integral component of the supportive care in the patients who are being treated for cancer. So what are the nutritional therapies available? Oral dietary therapies, enteral nutrition, parenteral nutrition, and immunonutrition. Oral dietary therapies, oral nutritive supplements, which are also called as ONS. When spontaneous oral protein per day intake is insufficient, we can use ONS, and the goal is to maximize the absorptive capacity of the digestive tract that has limited reserves, minimize GI symptoms, which reduce the oral intake. What is the role of protein? People with the cancer may need more protein. It is important to discuss your individual calorie and protein needs with your healthcare provider or registered dietitian. With some cancer, the metabolic processes can cause the situation which is known as hypermetabolism, and these affect how the body uses protein, fats, carbohydrates. So with the hypermetabolism, you may need to increase your calorie and protein intake, and discuss this with your healthcare provider or registered dietitian. Benefit of protein supplement. Supplementing protein in the form of protein powder is more convenient, easy to make, and then the dietary proteins. Can prepare the protein shake, drink them, or sprinkle the powder on the salad, smoothies, oats, or the other foods to get daily dose of protein. Protein powder are more useful to fight cancer-related weight loss, muscle loss compared to the dietary proteins. Whey proteins increases the production of natural glutathione, which protects the cell from cancer and eliminates cancer-causing agents. This is a unique therapeutic effect generating generally not produced by the dietary or the vegan proteins. Importance of the protein. Protein is needed for the body maintenance, growth, and repair. Protein is present in almost all the part of the body cells and has many functions such as formation and maintenance of the muscle, connective tissues, red blood cells, enzymes, hormones. The transporting many body compounds as well as medications, maintaining the balance of the body fluids, fighting infections, strengthening immunity, And generally, the diet provides the enough protein. However, while the patient is undergoing surgery or the treatment of cancer, the protein needs may increase. And it is important to be aware of the food sources of the protein to include these food at every meal and this snack. So these are the sources of protein. Will not go into the detail. We know them well. Enteral nutrition. Infusion of the feeding solution, so the tubes into the digestive tract, bypassing the obstructions, provides slow continuous infusion of the nutrients to maximize the absorptive capacity, can be safely used, provides the access for the nutrition which are not palatable. So this is the recommended cancer in protein intake for the cancer patients. Calories 25 to 30 kilocalorie per kg per day. Glucose less than 5 gram per kg per day. Lipids 0.5 to 1 gram per kg per day. 24 hour continuous perfusion is better tolerated. Protein requirement 0.25 to 0.35 gram of nitrogen per kg per day. That is 1.5 to 2 gram of protein per kg per day. Enteral or parenteral nutrition, both are having advantages and disadvantages. In practice, two methods should be complementary and not competitive. Home nutrition support. Cancer is leading indication for home parenteral and enteral nutrition. Home enteral nutrition is safe and effective means for long-term nutritional support in patients with severe malignant dysphagia. Proven efficacy in the selected patients. Home parenteral nutrition in the patient with chronic absorptive disorder. So nutrition therapy in oncology is evolving from supportive care to anti-cancer therapy. Correction of malnutrition, preservation of muscle mass leads to the modulation of the pharmacological and physiological effect of the chemotherapy and radiotherapy. Goals of oncology specific nutrition: maintain, increase body weight, preserve or improve muscle mass and function, reduce inflammation, improve immunity, and improve tolerance to the multimodal cancer therapy. High protein, high energy, consider omega-3 fatty acids plus minus glutamate. And this is a systematic review. Oral nutrition interventions are effective at increasing nutritional intake and improving some aspects of quality of life in the patient with cancer who are malnourished or are at nutritional risk but do not appear to improve mortality. So this is a retrospective analysis of head and neck cancer patients receiving early nutrition intervention prior to chemo-RT versus home nutrition. So you can see that those patients who received nutritional intervention, they had less of radiation therapy breaks, days of RT delay for the toxicity was less, hospital administration for mucositis was less, planned chemotherapy completion was more in those patients who received nutritional therapy. Weight loss from the baseline occurred less in the those patients who received nutritional therapy. So significant reduction in weight loss, interruptions in radiation treatment, and unplanned hospitalization. So this is a retrospective monocenter study in 139 patients with stage 4 or 3 head and neck squamous cell carcinoma receiving combined chemoradiotherapy intervention. 61 patients, that is 44%, received prophylactic PEG tubes, while 56 did not receive PEG tube. So you can see that the cumulative duration of interruption for toxicity was more in those patients who did not receive PEG tube versus 100 days for those who received PEG tube. So the patient of NSCLC receiving ONS EPA significantly improves energy, protein intake, body composition, and increased fat and decreased fatigue, loss of appetite, and neuropathy. Coming on to the micronutrients and oncological intervention, the recent studies they have provided increased evidence that treatment is tolerated better with increase in the patient compliance and lower rate of treatment discontinuation when micronutrients such as selenium are added to appropriate to the patient's medication. Nutrition supplement tailored to the individual background, diets, genetics, tumor histology, treatments may yield benefit in the subset of the patients. Energy and substrate requirements So these are ESPEN guidelines on the nutrition in the cancer patients, vitamin and trace elements, and immunonutrients. Immunonutrients, they improve lean body mass, reduce infectious complications, wound healing, prevent emulgate treatment-related side effects like diarrhea, mucositis, restore organ functions, and improve overall clinical outcomes. So screen all the patients with cancer for nutritional risk early in their course of care and focus on the increased nutritional intake, decreasing inflammation and hypermetabolic stress, and increasing physical activity. The take-home message is malnutrition in oncology is fairly a frequent problem. Oncology patients are in very high risk of malnutrition and therefore increased risk of complications, length of hospital, stay and poor quality of life. Nutrition support started early helps in completing treatment and improving many outcomes. Nutritional strategies modulate or reduce cachexia, improve quality of life, oncology treatment tolerance, and survival in the cancer. Thank you so much for your patient listening. Any questions or comments, they're welcome. Garima?
Hello. Yes, sir.
So if there are no questions in chat box, we can close the session.
Yes. Yes, sir.
Thank you so much for being here. And good night to all of the attendees.
Thank you, sir. Thank you, AstraZeneca. Thank you, Zambra. Thank you, Novartis. Sir, can we close the meeting?
Yes.
Thank you, sir.
Support team, kindly